Testing 1 2 1 2 3 1 2 3 1 2 3 1 2 3. Test 1 2 3. One two three 1 2 3. Test 1 2 3. Test 1 2 3 1 2 3. Test 1 2 1 2. One, two, three, 4. 1 2 3 4. 1 2 3 4.
It's 8 o'clock, okay. Are we good? Yeah. All right, good morning, everybody. Hi, good morning. Everyone has their breakfast, and I was told to start promptly at 8 o'clock because they're on a very strict schedule. For those people watching me virtually and watching everyone else virtually, good morning also. For the audience here today, I will be able to take some questions. For people watching online and virtually, you're going to need to write down your questions. Those will be emailed to me or any of the other speakers, and then I will, of course, respond. If you're emailing me, Dr. Kaufman, just put in the header, Pain Talk, St. Vincent's, and I'll know exactly what we're talking about. Okay, and everyone can hear me? Yes? Great. Okay, so I'm Dr. Andy Kaufman. I'm a professor of anesthesiology at Rutgers, New Jersey Medical School, as I say, in beautiful Newark, New Jersey, by New York City. My background is anesthesiology as well as pain medicine, and I've been practicing full-time pain medicine for over 15 years while being at the medical school. So I see patients, I have a large patient load. We also do some clinical research and a lot of teaching going on. So we're going to move along on prescription drug misuse and addiction. These are some of the hot topics currently. Let's see if that works. These are my disclaimers. Some of the objectives for today, want to try to understand some of the neurobiology of addiction without getting into it too deeply. I'm not an addiction medicine specialist per se, so I want to give a little bit of an overview, but I don't want to dive too deeply into it. We do want to understand misuse and abuse. What does that mean? What's the definitions of that? Some of the recognition of addiction behavior in your practices. What are some of the little touchstones? What are some of the red flags that we need to be looking for with addiction? And then how can we proper screen patients? Nothing's ever going to be perfect, but there are some screening tools that we can use that have been vetted that will help us when we decide that it is appropriate to prescribe an opiate for somebody. All right, let's get in some short definitions. This is from the American Society of Addiction Medicine, and definitions of addiction have changed over my practice lifetime. They've kind of evolved, but this is the newest one. So we can see addiction is a primary chronic disease of the brain, reward, motivation, memory, and related circuitry. Dysfunction in these circuits lead to characteristic biological, psychological, social, and even how they put in spiritual manifestations. It's reflected in an individual pathology pursuing reward and/or relief by substance use or other behaviors. So very different definition of addiction than when I was in medical school. This is taking in not just the hard science of it, but also the social aspects and even some of that, as we said, the spiritual aspects. We can read this a little bit later. I believe all my slides are in your handouts. So now, what about where do things start? Origin of drug liking. It's in the mesolimbic reward system. Okay, so is this pointer working? No? Guess not. Okay. So the mesolimbic reward system. So what happens with this? The drugs stimulate mu-opioid receptors in the brain in the ventral tegmental area, the VTA. And I'm sorry I don't have my pointer, but the VTA area. And that produces dopamine release. That's considered by many to be the absolute pleasure chemical in the body. That when there's big dopamine release, that's where people get this flushed, wonderful, oh my God, euphoric feeling. And it releases it into the nucleus accumbens, the NAC, giving rise to the feelings of pleasure. So there's going to be a feedback loop, and the feedback loop is from the prefrontal cortex. And that's supposed to feed back to say, wait, let's hold on there. Let's not just keep going unopposed to this pleasure piece. So there's supposed to be the feedback piece. And it's supposed to help us overcome the drives of pleasure. Well, because some of these activities may not be safe. They may not be good for us. They may be dangerous for us. So that's supposed to be the backup there. But in patients who are truly make the DSM code for addiction, there feels to be that the feedback loop is compromised. There is that prevention, meaning that we don't have that prevention. So we just keep getting flooded with the dopamine, and there's no feedback coming back down to say, wait a second, this is a bad behavior. This is a dangerous behavior. We have to work on this. Now, the locus ceruleus is also an area that's important in drug dependence, but also locus coeruleus is a very important area when we talk about withdrawal from an opioid, and we'll talk about that in a little bit. All right, now what are effects of certain drugs that people take on dopamine, on the spike of dopamine? Oh, it is working, there we go, just couldn't see it before. So we can see just with morphine, and this is time over hours and percent of basal release in terms of the milligram dosing. So again, the greater the dose, the greater the response with that. Now cocaine in particular, look at the huge spike we get with cocaine. It's over 300, whereas morphine is below 200. I mean, cocaine is one of the hardest drugs for people to get off of. You can get people off of morphine, you can get people off of heroin sooner than you can get people off of cocaine. Cocaine is one of those just really bad drugs, but we can also maybe see why. Look at that spike in dopamine that's going on. Now, what about nicotine? Smoking, that's legal, right? We can smoke. Hopefully no one here smokes, right? I always give that disapproving doctor look about that. But look what nicotine does. Nicotine also releases dopamine. And then obviously alcohol does too, not to the same extent, but this is part of what we see. So even alcohol does release some dopamine in patients as well. All right, now what about amphetamines? Well, look at that spike, all the way up to 1,000. So when you have some of these meth heads coming in and they're smoking that, and well, you can see why. Look at the response they get. And obviously over time they need to take more and more to get the same amount of dopamine released to try to get that. And as any addict will tell you, they're always chasing that very, very first high. You know, when they were just naive to anything and they take a hit of that first drug, that is the greatest event of their lives. And then every other time they take something, they're trying to recreate that event, and it'll never happen again. You know, and talk to anyone who's ever been addicted, they'll tell you that's what happens. Okay, so what about some of the origin of drug liking? A whole different kind of concept. Particularly in our early stages of abuse, opioids, stimulation, and it's into the brain reward system, right? And it's the primary reason that people take drugs repeatedly. They're going to take an opioid, they're going to get release of the dopamine, they're going to say, oh, this is great, let's keep doing it again. And so they're going to continue to want to work with that. But sometimes it's not even about the simple drive for pleasure. Some of it's related to, you know, I can't get into withdrawal. I don't want that feeling. I don't want the high, but I don't want that feeling of withdrawal. And this is to talk about tolerance and dependence. So a lot of times when people are taking drugs, especially with opioids, they're taking it not to get high, but not to feel like crap. They don't want to get sick. So you can see now it's a balance. They're on it for so long, they don't know what to do to get off, but they know if they don't take it, they're going to feel awful. And they don't want that awful feeling. They're not trying to get that high feeling. They're just trying to prevent that sickening feeling. Okay, so what about some dopamine D2 receptors? See how they're increased by addiction? And again, these are scans of the brain. So let's look at cocaine again, and we can see the light up areas in here. And what we're doing is DA-D2 receptor availability. Now this is when in a control patient, and this is an addicted patient, and you can see that just changes over time. You can see the brain is constantly changing in terms of where things are over the addicted versus a control, meaning like a first-time user here. See, the areas are shrinking, so they can't really access those sites as much. Now, what about withdrawal? Why do we go into withdrawal? Well, again, let's go back to our mesolimbic system. Now, this also has to do now with the locus coeruleus. Now, we talked about how that's tied in with the VTA and the NAC, and we talked about the locus coeruleus. Let me just make sure. Here we go. So what happens now, and again, you can follow along with this. Our body always wants to be in the middle, right? We want to be in that middle phase, that 50% phase. We don't want to be too much over here. We don't want to be too much over here. So we have to accept that the body's always looking to come to a middle ground. What happens when someone takes an opioid? They're opioid naive and they take a big dose of God knows what, or we give them too much in the operating room or recovery room, and all of a sudden their breathing slows down. Why is that? Well, the locus coeruleus is the engine that says, okay, when you go to sleep, we're going to make sure your heart beats, we're going to make sure you want to breathe, we're going to make sure peristalsis continues going. It keeps working with that. Why? It's releasing noradrenaline. And it says this is how we're going to pace our body. So when you take an opioid acutely, you're blunting all of that. So you've now shifted it over this way. Now when it's too much too soon, it overwhelms the system and people stop breathing, right? We get respiratory depression. Now on the other hand, then if it's given and it slows down, the locus coeruleus says, wait a second, we got to pull ourselves back over to the middle, and to do that, it needs to secrete more noradrenaline. Now if it's secreted that much, you'd be all the way over here, but because you would pull this way, you're right in the middle again. So over time, as you take more and more of these opioids, locus coeruleus is continuing to pump out a lot to keep you in that middle ground. So what happens when you stop acutely? Like all of a sudden they can't get access to their drugs. Well, all of a sudden there's no pull this way, and all you get is a sudden shift over to the right. And so what do you have then? You have too much noradrenaline. So what do people describe when they go into withdrawal? Shaking, chills, profound diarrhea. They're like wired, they're like this, right? Now, no one's ever died of acute opioid withdrawal. You just feel like crap, and that's what I'll tell patients. But then the body's going to go, wait a second, we're doing too much again. We got to slowly pull ourselves to the middle ground. So that's why when people go into this withdrawal, it could take anywhere from, people say, from 5 days to 7 days to 10 days to even 2 weeks for the body to almost reset itself back to that middle ground. Okay? So that's how we talk about withdrawal. So this is all in that mesolimbic system that we're talking about. Okay. So what is addiction in and of itself? There are some multiple models about this. There's a cognitive deficit model, and it proposes that the PFC signaling to the mesolimbic reward system is compromised, that it's a genetic compromise, that it just wasn't wired correctly with addictive disorders, and therefore they have reduced ability to use judgment. Remember the prefrontal cortex, to be able to use judgment to say, wait a second, this is a dangerous thing. This is not a good thing to be doing for myself. And therefore they can't restrain impulses, and they're predisposed to these drug-taking behaviors. So there's one model associated with this. Now, the change set point model, this is a different model of drug addiction, has a lot of variants, and it's based on altered neurobiology of the dopaminergic neurons in the VTA. Remember we talked about, and again you can reference back to the mesolimbic there, and the NA neurons in the locus coeruleus during the early phases of withdrawals and abstinence. So the basic idea is that drug abuse alters, in other words, you come in, kind of use the word normally, hate to use that word, but the drug abuse itself alters biologic and physiologic set points. So even though we want to get back to that middle ground, by taking the medications as long and sometimes as hard as people have, you've now reset the body, and it can't go back to that original point that it would like to. So that's an altered set point. Now let's look at some literature. In the Journal of Pain in 2015, Bowles et al. Looked at rates of opioid misuse, abuse, and addiction in chronic pain. So particularly looking at a chronic pain patient, not just someone who said, I'm just going to take drugs, I started as a kid, I never had pain. No, they're looking at, in particular, the chronic pain subset, because that's what we wanted to look at today. And they did a systemic review. And they found that rates of addiction, true addiction, were between 8 to 12%, even in the chronic pain patients. And that kind of mirrors society. That if you look at all comers, the rates of addiction are about 8 to 12%, not just in chronic pain patients, but in everybody. That's pretty standard number. Okay. Now, in 2016, the National Survey of Drug Use and Health by SAMHSA, which stands for Substance Abuse and Mental Health Services Administration. Until I started doing some research on this, I never knew we had one of those. So we do. Okay, so let's look at some of their nice graphs here. So this was, when we talk about the past year, this was 2016. Past year prescription pain relief misuse among people age 12. And I know I was down here another time, and people couldn't believe that. They look at starting at age 12. Not at age 18, not at age 21, but at age 12. So that's kind of a sad commentary in and of itself. And let's look at age group. So in the groups 12 or older, in terms of this is now prescription pain reliever misuse. So this is not everything in terms of illicit drugs. That's why. So the rate of addiction for prescription is 4.3% of the entire population age 12 and greater. And that counts for, and that's number of people in thousands, that's over 11 million people. So we can see that. Now if we break it down into groups, just age 12 to 17, we see that that's 3.5% of that population. The largest subset is the 26 and older, though, in terms of 8 million. But in terms of percentages, it's the group 18 to 25. And we're not surprised by that. You know, we talk about continual developing brains. Males, which my wife likes to point out, are our brains ever developed, as she said. But that's where the brain's still developing with males. We know it could be up into the early 20s. You can see that risk behavior in that 18 to 25 group is very, very high. And so you can see percentage-wise of the population, of their subset, they're the highest in terms of 7.1% of their share of population versus the 12 to 17, I want to say only, I hate to use that word only, 3.5% versus 26 and older, and that's just continued. There was no upper limit with that. It's going to be 3.9%. Okay, now, in terms of selected pain relievers, what do they like to abuse? What do they like to take? What's their thing? What's going on? So in terms of, again, we talked about any pain reliever misuse, that's at 4.3% over there. We can see that over there. The still number one and running hard is hydrocodone. Now for years, hydrocodone was probably number one because it was a class 3 drug as per the classification of the DEA. Is everyone familiar with the classifications of drugs? It has to do with addiction potential, and these were created in the early 70s when actually Richard Nixon created the DEA. And they created the way we classify drugs and medications. So class 1 drugs are very, very addictive, but have no medical use. Class 2 are considered very, very addictive, but have medical use. Class 3, somewhat addictive, but have, and we go down all the way to class 5. Let's give an example of what's a class 5. Pregabalin, Lyrica, is considered a class 5 controlled substance, believe it or not. So to prescribe Lyrica, you must have a valid DEA license, and in the state of New Jersey, I also have to have what's called a CDS license, which is Controlled Dangerous Substances License. I think it's always a way for the state to make a little more money, but that's a whole nother issue. Why do I have to have that if I have a DEA? I just had to renew it, That's another $30. So I'm sure. But in other words, that's a control, Lyrica. Why? Because in some lab rats, and now if you've noticed, gabapentin is now being tracked in New Jersey's prescription monitoring program. Gabapentin is now being tracked. It's not controlled, but there are reports of abuse among 18 to 25-year-olds. Shocking. And which I have no idea how they're abusing gabapentin, to be quite honest with you. But now it's being tracked. So when I look up my patients in the PMP, it'll come up gabapentin also, which we always think of as a safe medication to work with neuropathic pain, because we don't want to give them an opioid, right? So but that's being tracked now. So the hydrocodone was a class 3. For the life of me, I never understood why, because it is still a very potent drug. And if you look at ratios of drugs, it's equal to oxycodone in terms of potency. And there's some reports of it being even being a little more potent too. But it was changed, I want to say 4 years ago, please don't hold me to that, from a class 3 to a 2, and tramadol was increased from a 4 to a 3. So that bumped it up. What's the big difference going from a 3 to a 2? You can't call it in. You can't give renewals on it. That changes it entirely. Whereas a class 3 drug, you can call it into the pharmacy, you can say, here's a script and I gave you 2 renewals. So that was one of the reasons that hydrocodone was just really readily available. The problem with hydrocodone for addicts was that it's always compounded with something, right? It's in Vicodin, it's in Vicoprofen. So it has Tylenol, it has ibuprofen. There is one single form of hydrocodone right now, but it's an extended release. It's called Hysingla. It's made by Purdue Pharma, which now has a kind of a bad name in the industry, acting extended release format of it. So there was a reason that availability, but it's interesting that it's still kind of number one. Oxycodone being number 2 in terms of percentage of like, Codeine, for some reason, is still number 3. Tramadol, everyone thinks it's when it first came out, everyone said, oh, it's a non-narcotic. Isn't it an NSAID? And I'm like, no, it's not an NSAID. People always confuse it. They're confusing it with Toradol. Right? Toradol is an IV, mostly, and if you work in a hospital, you can get a PO, but you can't use Toradol for more than 5 days because it'll rip a hole in your stomach because it's so potent. But people confuse Tramadol and Toradol, but it's a controlled substance, and it's a drug of abuse. Look at it. It's above morphine, it's above methadone, it's above fentanyl. Remember, this is prescription, so we're not talking about fentanyl that's coming in from Mexico, China, laced in people's heroin. We're not talking about that. We're talking about prescription medications. So I have to qualify that statement. But you can see that these are the popular ones. So Tramadol you still have to be very careful with. I don't know. I don't prescribe a lot of codeine at all, ever. I don't know if a lot of people do. Remember, codeine's a prodrug. It gets metabolized only 20% of it to morphine, which is actually the active product of it. Dentists always like codeine a lot, again, because it's a class 3 drug. So it gets prescribed. Some gastroenterologists will prescribe it as opposed to tincture of morphine to help slow the bowel down in certain cases too, because it's very constipating, codeine. All right, so now let's talk about misuse, right? There's different definitions with that. So misuse is use of a medication for non-medical use or other reasons than prescribed. That's the definition of misuse. Right? It can be willful or unintentional use of a substance in a manner not consistent with the legal, that's the key, legal or medical guidelines, such as altering the dose. You know, doc, I know you gave me 1, but when I take 2, that really helps me. That's misuse. It was prescribed as 1 tablet, you know, Q8, PRN. And when you take 2, you're not following directions, you're actually misusing it. And that's a willful decision. You said, I am going to take 2 tablets. I'm not following your directions. I don't believe what you told me was correct. I know better, right? Or saying to a friend that, oh, you hurt yourself. You know what? You can't get to your doctor. You can't afford to go to an urgent care center. Why don't you just take one of these pills? Now, you think you're doing the right thing for your friend, right? It's like saying, well, you know, hey, you're short on beer? Here's one, right? But you aren't. That's willful misuse, because how do you know that that drug's not going to interact with something that they're taking, or do they have an allergy to one of the byproducts or one of the prodrugs of it? So you could be unintentionally hurting them. So that's still willful. And that's why we talk about having harmful consequences. Now, let's talk about abuse. Now, this is a DSM-4 definition. This is in the psych books, and the DSM-5. So in DSM-4, they define this, and I talked to my psychiatry colleagues about this. It was misuse with consequences. So they took they took the misuse, which was kind of somewhat benign, and then when it becomes abuse, it's misuse with consequences, which I never quite understood that. To me, it's all kind of part and parcel, but I'm not a psychiatrist, nor do I ever want to be one. The DSM-5, on the other hand, says, okay, we need to work with this a little bit. And they combine the DSM-4 category of substance abuse and substance dependence into a single, now what you'll see is substance use disorder. And that's seen in a lot of literature, for pain literature now. They'll talk about rates of SUD, substance use disorder. And it's measured on a continuum. It's from mild to severe. So that's in the literature now, that's what you're going to see a lot of, is this SUD definition. Okay. So, what's also from the psychiatry colleagues? It's the use of a substance to modify or control mood. You know what? I need to take this because otherwise I'm just feeling down in the dumps, or I can't function without it. They're not looking for a high per se. They're not chasing the high. They're just saying, I need this to function on a daily basis. And it's in a mindful manner. And it's illegal, or it could be harmful to you or somebody else. What's to someone else? Let's just look at alcohol abuse. They go out, they want to go to they don't think they're doing anything bad. Then they get behind the wheel of the car, and you hear about them hitting a minivan with 5 people in it and killing them. The drunk driver never dies, right? You never see the drunk driver die. They just kill everybody else because they're just all floppy and loose, and they never get hurt, which is one of those weird things. But it's harmful to themselves. They may not even know it's harmful to other people too. And consequences, accidents, injuries, blackouts, they develop legal problems. aberrant sexual behavior, which puts people at risk for HIV and hepatitis. And actually, hepatitis is worse than HIV right now. I tell my residents when we're doing procedures, I say if I ever see someone recapping something, I literally smack them in the head. And I say to them, everybody in the world has AIDS and hepatitis except you. I don't care who you're looking at. You don't recap. But hepatitis is actually worse than HIV right now. It's much more manageable. People are getting sicker and sicker with that, so kind of an irony. So what are some of the abuse risk factors? Well, we know family history of alcohol or drug abuse is very, very strong, especially first-degree relatives. And I had a story of one of my patients who did not know her father had been an alcoholic because he had been clean and sober for 30 years, but he never told his kids. And the irony here was that she was hurt in an accident. She came to our trauma center. She had to be sent out on opioids. When she went to rehab, then she followed up with me. We could not get her off these medications. We had to send her to an addiction outpatient because we couldn't get her off of it. Finally, her father came clean and said, you know what, I'm an alcoholic. Then it made sense. And now she understood why their house was always a teetotaling house. She just thought it was just the way they were being brought up and their religious belief, but it was because that he had been such an alcoholic and that was how he was going to stay sober. But he didn't disclose this. It's almost like saying, well, we have a family history of cancer, or we have a family history of diabetes. That's part of an important family history. So this girl now understood. So when she had to come back for another surgery, we did a lot of alternative techniques to not have to expose her to an opioid, because we now had a better understanding, and because of that she had a much smoother course, because we knew part of her history now. That's so important. Believe it or not, previous sexual abuse is very strongly tied into abuse. PTSD, and we see that a lot with our returning veterans, and they're really working very hard with that, or any other situations. Any psych history, especially some of the other behaviors such as schizophrenia, bipolar disorders, personality disorders. Socio-demographic factors, it's kind of a big, wide open can of worms there. And age less than 45, that's when we tend to see that. Okay, so this is from drugabuse.gov. Again, the more you look for things, the more you find things you didn't know existed. And they talk about the 3 C's in terms of trying to recognize opioid abuse or addiction in patients taking chronic opioids. In other words, they're on it. What are we working about? So the 3 C's: loss of control. Lost or stolen. I was in the airport and TSA must have taken it out of my bag. I've heard that one a lot. Which I always love that. I was in my bag. I packed it. I know someone stole it out of there. I bring my whole bottle with me. I'm like, why would you bring your whole bottle of medication somewhere? Where are you going? You're not going on vacation for 3 weeks, right? So I've heard some great stories. Also the calls for early refills. Oh, I dropped 2 pills down the sink. That's always the good one, right? I actually lost a pill, so I'm going to run short, doc, or I'm going to go on a trip. Look, my patients go on vacations, right? And so we just had another patient came in. I said, okay, I need to see the airline tickets or where you're going. I document that. Why? It protects me, it protects the patient. So I can say, yes, I can give you an early refill. But we then make sure, and I say, look, you're supposed to be filled on the 28th. I'm going to fill you on the 24th. That doesn't mean the next month you're going to get filled on the 23rd on a 30-day cycle. You're still going to get filled on the 27th. So you have to keep track of your fill dates with that. And once in a while, that's fine. People go on vacations, but when it's that constant pattern, you're going to go like this. Time, right? No, we're not doing that. Or seeks opioids from other sources. Now, that's been a big deal now that we all have PMPs, right? We can look at that. I know New Jersey right now, I'm tied in to, I think, 18 other states right now. I was able to look up Maine the other day. I was so excited because I had a patient that was up there. But it's nice because now you can track and say, and it's state law in New Jersey that before I issue an opioid, I must look at the PMP. And that's also required in Alabama. You need to look at your PMP before you do that. In New York State, you can't even prescribe because everything is done electronically. You can't even handwrite anything. Before you can get to the prescription part, it's called the iStop program. You can't even get to it. You have to go into the check piece. You have to say that you checked it, download that, and then it'll allow you to get to the e-prescribe portion. So that's even an extra layer. What we do in our EMR is that we always go into the PMP, I cut and paste, I put it into the patient's EMR record, so if anyone looks at it, they go, yep, it's all there. Of course, that doesn't add any time to my day and make me get home much later. It's ridiculous. And withdrawal symptoms noted at appointments. When these patients are coming in, are they jonesing a little bit, right? Are they a little sweaty when they're coming in? Do they not look right? Are they tachycardic? Are they hypertensive? Do they say, gee, I'm feeling nauseous today? No, those are signs of withdrawal. In other words, when they came to your office, have they been without medicine for 3 days or 2 days? Are they starting to have those signs? You need to kind of look for that. The other C, craving, the preoccupation, where they're like this, like, I have to make sure, are you sure you're not going to be in the office? I need to make sure I get that prescription today because I have to fill it today. If I don't fill it, that's that very, we would say anal, but that's that craving. Recurrent request or increase, it's helping me and I want to stay at work. Can I just have one more pill? This is the bargaining part. Not a huge amount, just one, doc, that's all. Just one more pill a day and I'll be fine. But why? What's gotten worse? Has anything gotten worse? Has anything changed? I don't see anything on your physical exam. Objectively, the exam's exactly the same as it was. Nothing's changed, right? So you have to, when they ask for that. Increasing pain despite lack of progression of disease. That's what we're talking about. X-rays are staying the same, MRIs staying the same. Now, we don't treat MRIs, we treat people, but a good clinical exam is still not showing any changes. Right? What are you saying with that? Or dismissive of non-opioid treatments. I tried physical therapy 5 years ago, did nothing for me. I'm not doing it. It'll never work for me. I send people for chiropractic care, I send people for acupuncture, I send people for physical therapy. Where we are too, there's an excellent family medicine osteopathic program that does osteopathy manipulation. I utilize that. Why? Because it all works. It doesn't work for everybody, but each piece someone's going to get a response with that. But when they say absolutely not, they have a blanket no statement. And the other thing, despite negative consequences, the oversedation. Family members come in with them, they say, he falls asleep in his face with his face in dinner. It's like, boom, they're out. We go out to dinner, it's embarrassing. They fall asleep all the time in a movie. What's going on with that? They're just non-responding the way they should be. Or decrease in activity, they just don't go out anymore. I had one patient, we were weaning, I had inherited him from another doctor who had retired, and I said, listen, I'll take you on as a favor to this guy, but I will not continue what he's doing, we're weaning you. And the family was like, thank you, right? But what happened was he ended up hoarding medicines. And he went to his son's graduation from Rutgers, which is our state school. We don't have a University of New Jersey or like that, University of Alabama, we have Rutgers. Named after a guy who donated money and then went bankrupt and asked for his money back, but they still named it the school after him. So this is in the 1700s. You got to like that, right? Welcome to New Jersey. And so they found him in the car asleep. They didn't know where the hell he was. They were calling his cell phone. He had passed out in the car because he had hoarded medicines and took a whole bunch. He missed his son's graduation. You think he had a problem? Yeah. And at that point, the family was like, no, we're not dealing with this. And I'm like, good. Let's get him into a place. So that's what we have to look at. These are all kind of extreme examples, but it really ties in. Okay. Now, let's recognize the problem from a social. We talk about withdrawing from social recreational activities. We see changes in mood and behavior in patients, financial problems. They just can't manage their money. They're getting late to work. They're getting fired from work. We've seen that. Bad, reckless decisions, a missing school. Suspension from school, as we talk about with kids, or companies just saying, look, we don't want to deal with you anymore, we're firing you. So not working, there we go. All right, and some of the physical signs that we're going to look for, and again, these are, I'm not going to go through all of them, they're in your packets here, but these are things that we're trained to look at, right? We're trained to look at differences and changes in patients, and we have to look at what can the sedatives, anti-anxiety versus the stimulants do with all these, and opioid painkillers. So these are just kind of a broad, when patients are coming in, what do you look for if they're having a constellation of symptoms? Should you say, are they taking something they shouldn't be taking? Are they now a Xanax addict? Are they now getting it from God knows how many places? Are they coming in, they're just unsteady, they just can't concentrate? What's going on with that? Can we, urine drug test them? What can we look for? So this is kind of a general piece that you can look for with that. Okay, so Patient comes in to see you and you say, you know what, I really believe they benefit from the use of a low dose of an opioid. Remember, it's a tool that we have. It shouldn't be, it's not a zero. You know, the world is not going to be opioid free. There are instances. In our practice, we probably have about 10% of our patients on an opioid. We're a busy pain practice because we look at alternative techniques. We do interventional work. We do spinal cord stimulation. We do intrathecal pumps. We use alternatives with intrathecal pumps such as Prialt, which is a presynaptic high voltage calcium channel blocker. We'll put baclofen in. You know, we do other things. But there are some instances where a low dose of an opioid is appropriate. You know, you just can't help it. There are that group of people. So, okay. I got to use it. How do I protect myself? How do I protect my patient? So what can I do to help screen? Nothing's perfect. And I've been burned once or twice in my practice when I thought I did everything right, and you'll still catch it because you're still looking, but you're like, how did I miss it? And you look back and you go, we didn't miss it. We tried to do the best we could. All right, but that's the case. Is you're gonna really screen things out if that's the case. All right, so what can we do? Now there are some abuse screening tools. And everything has an acronym. We're going to look at SOAP, we're going to look at ORT, and we're going to look at DIRE. Okay, SOAP, Screener and Opioid Assessment for Patients with Pain. Okay, wish I can come up with these. There's several formats that are available. There's either a 4-question, 14, or 24. We use the 14 question, and here it is. And this is free online, by the way. If you type in SOAP, you can get these free online. So you can go print them out, and because people want people to use these. So these are not proprietary. We're going to have to pay a fortune to use these. So let's look at some of the examples of this. And so it's 0 through 4. You know, how often do you feel your pain is out of control? How often do you have mood swings? How often do you do things that you later regret? How often has your family been supportive? You know, saying, how often my family working with me? How often have you been told you have a bad temper? Compared with other people, have you been in car accidents frequently? One patient that came in the other day, it's like, yeah, I've been in 4 accidents in 2 years. I'm like, I want to know where you're driving. I don't know what's going on with that, right? How often do you smoke a cigarette within an hour of waking up? That's kind of an addictive behavior, right? How often do you feel the need for higher doses of medicine? How often do you take more medicine than you're supposed to? Remember we talked about that misuse? How often have you or any of your family members, including parents or grandparents, had a problem with alcohol or drugs? Comes into the family history component of it. How often have any of your close friends had a problem with alcohol or drugs? Are you being exposed to that? So again, I'm not going to go into all 24, but you can see the tenor of what's going on here. And by having them filling out, it's, look, every patient that comes into me, I will ask them, do you drink, do you smoke, do you do any illegal drugs? They're asked and answered. And I'll always say, is there a family history of alcohol or drug abuse? So I do my own quick, that's mandatory, and I tell my residents and students to do that when they're filling things out. I want to hear that. And then depending on what we're going to do we then want to give them this more advanced piece? But you can see how, and you can read in your handouts, how this moves along. And then there's scoring. A score of 7 or higher is considered positive for risk. In other words, increased risk. It's not a perfect tool, but increased risk. And we just talked about that. Now, these have been vetted. Pasek is a psychologist who's done an enormous amount of work in pain medicine field, and they looked at this as a vetting and saying, what's the validity of this? And it provides excellent discrimination between high-risk and low-risk patients. So this has been validated. Chow et al., this is another psychologist, said high-risk score correlates with an increased likelihood of drug abuse. So these have been vetted out. So they are good, useful, these are 2 good, useful tools. And this was specifically for the SOAP 24 question, because it's much more detailed. Let's look at ORT, which stands for Opioid Risk Tool. Again, Pasek, he's made his career out of this, so you're going to see his name pop up a lot in pain work. Felt that this provides excellent discrimination, again, between high and low risk patients. And Webster, this is a father-daughter team, also found that it would exhibit a high degree of sensitivity and specificity for determining which individuals are at risk for opioid abuse. So again, it's a good tool. So what's the ORT? It's a lot shorter, okay? And it's 5 patient questionnaires, you can see. And you're going to mark that which one applies. It's severe, not severe, et cetera. So alcohol, family history, personal history, age, again, we talk about, right? history of pre-adolescent sexual abuse. This opioid risk tool really looks at that. Remember, we talked about that earlier as a key for that. And then psychological disease. So again, a low risk is 0 to 3, moderate 4 to 7, high would be greater than 8. So again, this is kind of a quicker and cleaner than the SOAP. Now, what about DIRE? DIRE stands for Diagnostic, Intractability, Risk, and Efficacy. And this was specifically designed for primary care physicians. And this is one that is a physician assessment tool. The other two ones that I was talking about, the SOAP and the ORT, those are ones that patients actually fill out and then you score. The DIRE is something that the physician will work with and fill out and then score. So it was designed for primary care use, and this was specifically looking at long-term opioid therapy, not short-term. This is not, you know, where someone comes in, they've sprained an ankle or they've fractured something, and you're going, look, you know, the Tylenol, the acetaminophen is just not cutting it. I'm going to give you 4 days of pills just to tease things out when it's healing. This is someone that you're really considering for long-term. Before we prescribe opioids for anybody, because of the practice that we always do assessment tools also. So we don't just say, oh, it's just for 3 days, we're going to do that. So Belgrade et al. Looked at this, and he said the patient's DIRE score correlates well with patient compliance and efficacy. They're looking at it a little bit differently. Compliance and efficacy for long-term opioid therapy. And this is the DIRE sheet here. They look at risk as psychologic, chemical health, reliability, social support, and you can see the diagnosis and tractability. Again, this is all in all the handouts. But this is one that you would fill out as a physician after meeting the patient, discussing it with them, marking these down, and then you would score that to say, okay, are they going to be a good candidate or not? Are they going to be compliant? So a score of 14 to 21, they may not be a candidate for long-term opioid analgesia. 7 to 13, not a suitable candidate. So there's definite, you know, not, maybe not. You know, nothing's a 0. Again, this is still you and your staff and whomever being vigilant at all times with that. So at least these are tools that will help us make a determination of whether we want to even go there or not. So these are nice to have in our toolbox, right? These are nice to have, and they've been vetted out well, so they know there's validity with this. So that's important also. Okay. One of the things I do want to mention too is that prior to prescribing any opioids to any patients, as I say, we never kiss on a first date. I always urine drug screen people on the very first visit. They do not get a prescription. And I always love when they say, well, I only got enough to get to the office to the visit. And this is a big problem with rehab centers that discharge patients that we've seen in the hospitals, where they say, here's 5 days worth. And you're like, come on, guys, you know, what if I'm not in the office? Like today, I'm not in my office, I'm here. So, you know, they need to give a little more than that. But it's always amazing that patients always seem to have a few extra pills, they never have a problem. So we will not prescribe on a first visit. I want to see office notes. Obviously, I'm going to check the PMP, and I want to see the urine screen. Because a lot of times, we'll, you know, not a lot of times, let's say 5 to 10% of the time, when we do our urine screen, patients said, I took this, their urine screen's completely negative. So that's lying to me. You know, lying to me on a first visit is not a good way to start a relationship, and that means that I'm not going to prescribe that. Or we get a urine screen, and there's stuff there that I go, wait a second, you're not taking this. Why am I seeing this in your urine screen? Again, that's another red flag. In the state of New Jersey, we have different laws than you have here right now. These are not patients that I'm talking that are opioid naive. In the state of New Jersey, if you want to prescribe to an opioid naive patient, you're only allowed to give a 5-day emergency supply. And what's considered opioid naive? Someone who has not been prescribed an opioid in the last calendar year from that date. So if I go into the PMP and I see nothing for a year, that would be considered naive. I'm only allowed to give 5 days. If I want to then continue that, I'm allowed to give another 25 days. That makes a month. And then by the state law, in the third visit, you have to do a urine screen. We do urine screens to begin with. We don't wait for that third. The other question I've always asked a lot is, how many times should I urine screen? The CDC recommends once a year. Well, to us, that's not enough. We tend to do twice a year randomly. You know, I had a patient that came and we did one, let's say February, and I did another one in May, and they go, well, I just had one. I go, well, that's why it's called random. You know, you're not supposed to know when you're having these done. So, but I urine screen everyone a minimum of twice a year. There are other patients that I do urine screen a little more frequently just because of background. We're a trauma center. We take care of patients that do have drug issues, that have hurt themselves, and we need to work with the surgeons. They're having wound care, so they get tested a little more often. But there's no mandate that they must be tested on a monthly basis. And then also you have to react to the test. That's really, really important. If you get a positive test back and you don't react to that, that's a problem. Such as, patient comes in 2 in the afternoon and they test positive for alcohol. That has to be a discussion you have to have with the patient immediately. So don't wait till the next visit. These tests come back, they cross my desk or my nurse practitioner's desk. We look at that. If there's an aberrant test, we call the patient up immediately and we document that phone call. So I'm not going to wait till the next visit and say, well, why were you positive for alcohol at 2 in the afternoon? And didn't we talk about the use of alcohol with opioids? You will not be doing that. And if they say, well, it's legal, I'm going to do it. I said, well, you have a choice to make. I understand it's legal, but if you want to drink, God bless, go ahead, but I'm not going to prescribe you opioids. That's a choice that I've made in my practice. And we'll talk about marijuana in the next talk, so I won't get into that quite yet, so we have to lead into something. But you need to react to these things. If someone's positive for Suboxone, if someone's positive for a drug they shouldn't have, you're prescribing them oxycodone, next thing they know they're coming up with hydrocodone, or they're coming up with hydromorphone. Why is that? What's going on with that? Well, the PMP says I'm the only one getting it, which means they're getting it from someplace else. You have to react to that. It's like getting a CBC and not reacting to the fact the hemoglobin is now 6. I mean, you would never do that. You'd be going, oh my God, we need to take care of this, right? Same thing with the urine screen. It's a test like any other test that you must react to that, okay? All right, we do have a few minutes for questions before I gotta jump to the other one, because if I'm running late, Lisa will kill me. All right, so do we have any questions right now on this topic? Yes, sir.
You didn't mention any penalties for prescribers related to all this paperwork.
Meaning legal penalties?
Does the state have legal penalties?
Well, no, the state doesn't have legal penalties per se, but remember, this is all adjudicated through the state boards of medicine. And state board of medicines will have their own investigative arm. I know that I've worked for the state, not worked for, but I've been asked by the State Board of Medicine in New Jersey to review a case. And I will review a case and I will look at it and say, was there a deviation? Was there not a deviation? In other words, I'll be asked to review that. It's very rare, and if you talk to people at the DEA, like in New Jersey, because I can talk that, there's 24,000 providers in New Jersey that can prescribe controlled substances. Between PAs, nurse practitioners, dentists, podiatrists, MDs, DOs, I mean, it's a lot of people. When you think about that, it's a lot of people, 24,000. We have a little bit more population than you have in Alabama. And out of that, less than like 1% or like 0.8% of that entire group has been brought up by the state board. So they're not looking for that. They're not just going to come into your office and randomly audit records. They're going to say, well, there's been a pattern here. We've been noticing something. A pharmacist has called and said, why are all these people coming in with these X number of prescriptions, from that, and that will trigger something. So, and the penalty would then originally be not criminal, but it would be, I hate to use the word civil, but it would be on a state board level of, hey, are you keeping your license, or do you have to take some educational classes to keep your license? And so and then you have to take another percentage to see what would be considered criminal. That's just infinitesimal with that. Yes, there was another question on the table behind? No? I thought there was. Yes, over here? Then I'll get back to you over there. One sec. Yes?
I've been seeing a commercial lately for, I guess the drug Narcan, and the patients who are getting opioid prescriptions should also get a prescription for Narcan just in case there's an accidental overdose. Does your office provide patients with that prescription as well, or how does that work?
We don't. Yes. There was a push that every time you wrote an opioid prescription, you should also give a prescription for Narcan. We don't do that. Actually, in New Jersey, you don't even need a prescription to walk into a pharmacy and ask for Narcan right now. I don't know what the rules are in Alabama. That's a good point. I'm going to look that up. I'm sorry? You don't need one, yeah. And you can just walk in and do that. I mean, there's Narcan in our middle schools now, for God's sake. It's just, you sit there and go, that's really sad with that. No, we don't give a prescription for that. Now, part of me says it's almost like a get out of jail free card. if you're giving this to the patient, say, here, just in case you dig too much, here, you can just give yourself this and you can wake up. No, I want responsibility with that. But it's nice that it's more ubiquitous, because why is that? Family members, especially for people who are taking illicit substances, not prescription pain medicines, but illicit substances, and they're worried, and they maybe found a family member down from heroin or God knows what, that they have this in the house for themselves because they can give it to them before they even call 911. But we don't do that on a regular. I don't do that in my practice on a regular basis. Yes, sir. There was a question in the back.
What quality of urine drug screens do you, in other words, a lot of my patients are not, they have no insurance, very low income, and I hesitate to give them a drug screen that's going to cost $500.
No, the question was, what quality of drug screens do we use? And his patients, they're low income. They can't necessarily afford these screens. There are a lot of companies. I work with a company called DrugScan. I don't know if they're now down here. I see this big LabCorp building. I walked around here the other day, gigantic LabCorp. With a lot of these companies, they have programs where they're not going to overcharge patients, especially if they have some, so even Medicaid, if they have that, or even Medicare, so you can look into that. But the standard of care with urine screens is that they have to be done with a gas chromatography and mass spec. Why is that? The old time, still old time at University Hospital, they got a basic drug screen that just says opiates. Okay, what the hell does that mean? What opioids? How much opioids? What are they? I want to know on a drug screen. So if a patient comes in and they're taking oxycodone, right? Oxycodone is going to be basically 3 phases: oxycodone, noroxycodone, and hydromorphone. That's going to be breakdown products, and we see that over approximately 3-4 days of breakdown. So if a patient comes into me and urine drug screens, they say, "Doc, I take my medicine just like you told me, clockwork, and I get a urine drug screen on them, and all I see is oxycodone. I don't see any of the breakdown products." I know that they took that pill like 2 hours before they came to my office, so they'd have something on a potential urine drug screen. They're not taking it on a regular basis because I'm not seeing breakdown product. So they're lying to me. If they say to me, "Doc, the last time I took a pill because I couldn't get into the office was 3 days ago." Okay. And then on the urine screen, I don't see oxycodone as a drug. I said, well, that's appropriate. I shouldn't see that. And I'm only seeing the tail end products. Well, that's appropriate. So I want to see breakdown products. So that's why we do gas chromatography mass spec. But with all these drug screen companies, please talk to them, because they'll always have some sort of program. And I know the companies that I work with will not overbill with things because they want other business too. But you need to do it as a standard of care. You have to. And contact several of them. There's not just one game in town. So that would be the advice I would give. All right, we have time for one more question. Anybody? Yes.
You mentioned earlier the cognitive deficits model of addiction.
Yes, sir.
In children that are under the age of 12, obviously ADD was one of the questions on one of the screening materials, but that would mean that any child that's diagnosed with ADD or has impulse control issues are predisposed to addictive behavior.
Well, again, I'm not an addiction medicine specialist, and so the question was, and I believe it was under 12 you were talking about, not 12 to 17, but under 12?
Yes.
Okay. Under 12, we talk about risk factors with something like ADD, which is diagnosed a fair amount at this point in time. It is a risk factor. It doesn't mean that it's going to be, that they're going to go into that. I would actually want to defer that question more to a true addiction medicine specialist, or even more of a child psychiatrist or psychologist with that. But again, any person with impulse behavior issues could be at risk for that. And we do know that. So that's something we need to be careful with. Okay? All right. Excellent. So we're at 5-2. I'm just going to go grab my water. And how do I get to the next deck? Lisa said she minimized it somewhere, so I'm going to beg my audiovisual person to come up, or Lisa to come up and show me where she hid it. Because I'm afraid if I touch something here, the whole system will crash. And I'm going to go grab my water. Like a minute or two just to stretch your legs and get more water or coffee. And we'll jump into the next one.
I had a patient come in asking for a large quantity of Phenergan. Is that a...
Phenergan actually can be an abuse. I've had patients addicted to antihistamines. Yeah, so you have to be careful with Phenergan. You know, we have one patient who, she was like ordering Benadryl bulk, and she was found passed out by her parents. And we see Phenergan a lot with sickle cell. They said, the opioid won't work unless I get high dose Benadryl or high dose Phenergan with it, because it becomes a sedative, right? So that can be, believe it or not, that can be a drug of abuse too. Isn't it amazing?
Well, I didn't know if it was an enhancer.
No, it doesn't enhance anything. That was the old intern's trick, where you give, Demerol and Phenergan. Phenergan's an antiemetic. It does nothing to open up opioid receptors. It does nothing to stop the breakdown of Demerol. It's just it was an antiemetic that would also be a sedative. So as an intern, 2 in the morning order, if you give them Demerol and Phenergan, they'll pass out. They won't be better, but they'll pass out and not complain to you until shift change. Let the other guy deal with it at 7 a.m., right?
I know that. Thanks for coming down. I appreciate it.
No, my pleasure. I enjoy coming down here. It's fun.
Will you be talking about your methods of weaning?
We could talk about that a little bit.
Yeah, we get folks in all the time.
There's no magic with it. I try to do like 10%. Like one patient I set up and I said, okay, we're looking at this over 6 months, and I set up milestones. This is the first month. So I said, okay, this is where we are. This is where we are. This is where we are. So I try to set up goals. In other words, you lay it out to them. This is what we're going to do over this period of time, therefore. Okay?
I think our guys would like to hear you.
Yeah, okay, I'll say something about that. Okay, we'll start pulling some people in from out there. I see everyone's kind of wandering in and out. No, actually, I love coming down here because you have a great food scene down in Birmingham. I'm very, very impressed by that. A month ago, I made sure I made the second I could, made a reservation at Highland Bar and Grill. That place was fantastic. Yeah, I went last night. My wife came down, and if I lived down here, I'd be spending a lot of money there. I'd be saving up and not eating for like 2 weeks and then saying, ooh, I'm having my meal now there. I don't know if you guys have been there, but wow, what a fantastic place. You can have a place like that here. A lot of great places in New York have closed because the rent has become so ridiculous just for the space that they said we can't afford to do business here. So you have a lot of people that train elsewhere and come down here, and their rent's going to be half the cost or an eighth of the cost, I'm sure. But boy, what a spectacular meal. That's why I'm glad I woke up and worked out this morning. I was after that. All right, I think everyone's back, and for Lisa, we're going to stay right on time for the audience here as well as the audiences elsewhere. I am still me here. So the next talk we're going to do is legalize marijuana and opioids. So we're going to segue into that and the whole thing of deadly crossroads, right? That's kind of an attention grabber. That's kind of a big thing right now, right? Marijuana is still, as I remember, illegal here in Alabama, medical marijuana, correct? Yeah, it's one of the few states that haven't gone caught on the bandwagon, so to speak. There's still a lot of controversy with that, even in our state of New Jersey. So let's look at some of the objectives for this talk. We want to understand some of the historical context of marijuana. This is not a Johnny-come-lately medication. let's understand the evolution of marijuana laws in the United States. This has been an ever-changing piece. And what are the interactions of opioids and marijuana? Why could they be dangerous? Why could they be maybe helpful? Okay, let's look at some of the historical. I love drug history. You know, everyone says this is new, and you go, no, it's not new. We've seen this before in different formats. Let's look at 2900 BC, the first modern reference to the medical use, not just the use of it, but the medical use of marijuana. Emperor Fu Sui mentioned it as a popular medicine due to having yin and yang, yin being, negative feminine, and yang being positive masculine. And what the emperor was saying was that marijuana balances the two nicely. So you should be using this because it'll help to center the body. In 1500 BC, this was the earliest written record in medicine in particular. It was listed in the Chinese Pharmacopoeia that this was one of their accepted medications. So this is in their codification process. In 70 AD, the Roman medical text cited cannabis to treat earache and to suppress sexual longings in their legionnaires that were being sent out hither and yon and conquering. And no, you should be smoking this so we're not raping and pillaging people. So that's what they wanted their soldiers to use this. Right? A little bit different than you say the US Army right now, right? So they told their soldiers to use this. In 1850, let's jump ahead a little bit, cannabis was added to the US Pharmacopoeia standards. 1850, so this is not, again, we're talking about medical marijuana in 2018. In 1850, it was listed down as a true medicine that can be used. In 1889, there was published in The Lancet, which was the leading journal at the time, this was from Britain, The Lancet, using marijuana in opioid withdrawal. Again, what's old is new again. You hear about people saying, maybe we should use marijuana to help with opioid withdrawal to get people off of prescription pain medications. And what's really cool is that you can actually look this up and you can read the article. It's in volume 133 from 1889, March 30th. And it was written by Edward A. Birch, who is the honorary member of the Calcutta Medical Society and physician to the General Hospital. And it was the use of Indian hemp in the treatment of chronic chloral and chronic opium poisoning. And this was the wife of the viceroy of Britain to India at the time. So she was an addict. And he was able to treat her with the use of marijuana to get her off of these medications. What about marijuana in the United States? Well, in 1890s, smoking of hashish became a fad in France. And just like things become fashion in France, they came over across the pond and people said, maybe we should try this hashish thing. Late in only in the 19th century, the use of marijuana began as a popular ingredient in many medical products, sold openly in pharmacies, right? In late 19th century, 1800s, there was no standardizations. There was not the Food and Drug Act yet. There was nothing like that. So pharmacies were mixing their own things and putting marijuana in it, amongst other things. It wasn't until 1906 that the Pure Food Act required labeling of any cannabis. So you could still do whatever you wanted to do, but you actually had to say, there is cannabis in here. Before that, it would be like, here's Dr. Ed's sleep medicine. Take this, and Lord knows what was in that. So here's some examples of this. This is one of my favorite things. This is a cannabis indica. Remember we talked about 3 different plants. This is made from the indica, and you could have just from the American Druggist Syndicate, so it was very officially made. And you can just get liquid cannabis indica. Now this is my favorite one. This was a cough syrup, and this was marketed to kids. Help them with coughing and sleeping. Oh, I'm sorry, I'm wandering out of the picture. I tend to do that. I've been told I wander. I've been told to stay in between here. I forgot, I'm sorry. I'm restricted, that's very hard for me. The cough syrup, look what's in this cough syrup. Alcohol, cannabis, chloroform, and morphia, right? And this was sold over, you walked into your pharmacy and said, we got something for you, right? This is great. You won't just knock one night, because you'll take this and you're only one night you're done. That's it. But imagine that. Imagine walking into your pharmacy and saying, and your druggist, and he'll say, yes, I have something that's wonderful for you. Oh my God, right? Look at that. But that was before there was regulation. But at least it was labeled. You knew what you were getting. So that was a step up versus that. But imagine that. And that was marketed for kids to get them to stop coughing, amongst other things. But these are just two examples with that. So what about in the 1900 to 1920? Believe it or not, after the Mexican Revolution, there was significant immigration. You know, people, just like today, wanting to get away from bad places where they may be shot or killed, and they go, let's go somewhere else where it appears safer, with a culture of recreational usage. This is part of a culture, this is part of religions, that they would use marijuana plants, peyotes. Marijuana began to be associated, unfortunately, with immigrants, with fear and prejudice against both. Terrible crimes were being attributed to both marijuana and the New Mexican population. Kind of sounds familiar 100 years later, right? Unfortunately. But again, you can see some of the prejudices that were occurring then in tying in patient populations to cultural issues. And this was in the early 1900s. There was a lot of articles you can read about that. So 1929, 1939, obviously the Great Depression. Marijuana was outlawed only at that time in 24 states. So it wasn't that it was outlawed before that. It was only then. And then there was quote-unquote research, and that's why I put it in quotes, because it really wasn't research that showed marijuana caused violent crimes and social deviant behaviors. It was also assumed to be caused by racially inferior or underclass communities. So we can see where, you know, there was no research involved. It was just, you know, inflammatory articles and how it was being quoted. So this is where these movies came out that Hollywood was forced to make about reefer madness. And actually, you can still find this on the internet. It's fascinating to watch. If you go on YouTube or somebody, you can find this. Watch this. It's just an amazing, almost caricature of the evils of marijuana. So, you know, women cry for it, men die for it. You know, the sweet pill. I mean, look at these. This is just so inflammatory, right? Youthful marijuana victims, drug-crazed abandon. Or over here, wild orgies, wild parties, unleashed passions. It's just, this is the inflammatory things that people were doing in the 30s. And this was being mandated by the government that Hollywood had to put these out. They were forced to put these out. And these are just two examples. All right, now in 1937, there was the Marijuana Tax Act. And this was a campaign against what we can see is we considered the evil weed. And this is actually by an act of Congress. And it was a statute that effectively criminalized marijuana at this time by restricting it to individuals who paid an excise tax for certain authorized medical industrial uses. So it all comes back to taxes. Remember, Al Capone was put in jail because of taxes, right? They didn't get him on murder. It was all taxes. So now it wasn't quite illegal, but they made it legal by putting all the excise tax on it. So it wasn't until getting up to 1944 where real research was done. This was the New York Academy of Medicine under then Mayor Fiorello LaGuardia said, we got to look at this. And so real research was done at this time versus the research that I mentioned before. So extensively researched report declared that, you know what, contrary to the earlier research and popular belief, use of marijuana did not induce violence, insanity, sex crimes, or lead to addiction of other drugs. So this was there trying to really look at it at that point, kind of debunk all these myths. Now we have to really jump up, and nothing got done until 1972. And this was the Schaefer Commission. And this was actually appointed by Nixon. Nixon said, you know, at direction of Congress, we need to really look at this. It was a bipartisan committee that said, all right, let's look at this. And their recommendation in 1972, bipartisan committee, was to decriminalize the personal use of marijuana. And Nixon rejected it entirely. So they set it up, bipartisan committee, everyone looked at it, and they said, you know, we should be decriminalizing this. That was 1972, guys. So this is not, again, this new thing that we're looking at. So then we have to really jump from 1972, really nothing got done until 1996. And I grew up in New York State, and this was under Governor Rockefeller, and more people got put in jail for marijuana possession at that time than ever before. It was just these very, very, very strict drug laws that were occurring in that when I was growing up in the 70s. So in 1996, California, like a lot of things they do in this country, they lead the way in a lot of things. They did Proposition 215, and they passed in California legalized medical use of marijuana. That was in 1996. They were the first state to do that. So currently 23 states, and that's why I have legal medical marijuana, that's why I put in there Alabama does not at this point in time. And then recreational use, Alaska, California, Colorado, Maine, I have 2 commas in there. Massachusetts just passed it because Maine did, Massachusetts did, and now I think Connecticut's going to because all the other states did and they don't want to lose out on the tax revenue. So all the states there, it's kind of like, oh, you did it, we better do it too because everyone's going to go over there and spend money and we want to get the tax. Vermont, Washington, and Washington, D.C. have legalized recreational use. New Jersey, there's fighting in the legislature right now. Our new Governor Murphy wants to make it legal because he says that it could bring like $340 million of tax revenue to the state. So that's his big thing. And also saying by doing that, we're going to free up police forces because New Jersey, believe it or not, has the highest rate of marijuana arrests in the country. Don't know why, but we do. So they would say they would free up a lot of court time too. So now that we've talked about some of the history of it, so we can say, hey, this is not a new concept. This is something that's been brewing for centuries, if not over the last 200 years in this state, or this country. So let's look at some of the science of marijuana and opioids now. Cannabinoids, and that's what we're talking about, and opioids both produce analgesia via a G protein coupled mechanism. Don't want to get too specific. Remember, a G protein is going to have 7 different receptor areas on there. And the bottom line is when you activate a G protein, it decreases adenyl cyclase, which causes an increase in cyclic AMP, and it causes inhibition of calcium channels. When that happens, you don't get signals, right? So we decrease signaling. So they both work in a similar mechanism. You also stimulate potassium efflux, right? So what you're doing is you're depolarizing the cell, or the cell or the transmission. So you don't get transmission. So they both kind of work the same way. Let's look at some literature. Abrams et al. Looked at cannabinoid-opioid interaction in chronic pain. This is Clinical Pharmacologic Therapeutics in 2011. Again, the N numbers of these studies are very, very small because to study marijuana in the United States is incredibly difficult. You have to get it from the government. They grow it in 2 different places. I think one place in Louisiana and maybe I think one the other place in Texas. And you have to really jump through hoops to get it right now. That's why most of the research, if you look in journals, is coming out of Canada or from Europe, where you can much more readily access it. Hopefully those laws are going to change a little bit. So in this study, they looked at 21 patients, not exactly 200, 300, or 2,000, right? So I preface it by saying very small subset. With chronic pain due to arthritis, neuropathy, cancer, and MS. So this is kind of all across the board, right? We're talking somatic pain with arthritis. We're talking neuropathic pain. Cancer pain could be a mixed somatic neuropathic component, and MS obviously is usually more of a pure neuropathic, but when you start getting severe muscle wasting and weakening, you can also have somatic pain on top of that because you get joints broken down. So what they looked at here was patients using morphine or oxycodone. This is average doses. 62 milligrams on average twice a day, or 53 twice a day, average doses. They gave them vaporized cannabis for 5 days. And again, short time period, not 20, not 30, not 80, 5 days. What did they find? They found that there was a significant decrease in pain by 27% on average. The patients they weren't told to stop using their opioids. They said, okay, these are the opioids you're using, these are your current pain scores, let's layer this in and see what happens. So they said, yeah, we got a little better, but no one took less opioids. So that's the next important comment. There was no change in area under the curve for morphine or oxycodone usage. It remained the same. So what was, the conclusions that they can come up with were like, okay, it enhanced whatever they were taking. Didn't, again, in 5 days, again, I say small, I hate to preface it, but I really want to. This N number was small, right? And the study design was small, 5 days. Now, maybe if they took it out to 5 months, would we have seen a change in area under the curve? Would people have taken less medication? Don't know. Whiting et al. Looked at cannabinoids for medical use. This was a systemic review and a meta-analysis. This was published in JAMA, Journal of the American Medical Association, in 2015. And they found that there was moderate not poor, but moderate quality evidence to support the use of cannabinoids for treatment of chronic pain spasticity due to MS. Looked at a very specific piece. Low quality evidence associated with improvement for nausea and vomiting with chemotherapy. That was always one of the prime reasons they were using marijuana. Weight gain and HIV. Sleep disorders or even Tourette's. I wouldn't even have thought of Tourette's, but even Tourette's. So this was in 2015. All right, now, Dagenhart, I'm probably butchering his name there, looked at adjuvant cannabis for use for chronic non-cancer pains. And this was the POINT trial, the pain and opioids in treatment. And this was in drug and alcohol dependency in 2015. This is a study out of Australia. Now, this is a much better N, right? This is over 1,500 people who had prescription opioids. They were getting prescription opioids for chronic non-cancer pain. So they separated that whole population out. And they had data collected on cannabis use. Were you using it or not? They weren't prescribing it. They were just saying, are you using it? And they also said, did you make the cannabis use disorder, that new ICD-10 definition that we talked about in the other talk? Did you make that criteria to say, hey, do you really have cannabis use disorder? And then they also took some data on, were you taking it specifically for pain or not? So they had very specific data points. So they found that 16% of this patient population of 1,500 people said they were using cannabis specifically for pain. They weren't being prescribed opioids, but they were now supplementing it for pain. The people who reported this tended to be younger. Again, it's kind of the data that we saw from the last time. And they tended to report greater pain severity, much greater interference with their activities of daily living, and poorer coping skills with pain. So these were kind of their risk factors for saying we're going to use cannabis in addition to the opioids that they were being prescribed. Now, in this patient subset, they looked at them and said, these people also tend to be on longer and higher doses, meaning that this 16% tended to be on opioids for a longer period of time versus the other patients, and tended to be on much higher doses versus the other patients, and were more likely to be non-adherent with their opioid use. So they're saying, are we subsetting out? So 12% fit the ICD-10 for cannabis use disorder. Of this 16%, 12% of them did fit the cannabis use disorder. Almost 43% never used marijuana to treat pain in the bigger group. So this was not a ubiquitous thing. They're not saying, oh, let's all kind of work with that. So kind of interesting data points. So what did the authors conclude from this? They felt that there was greater pain relief in combination with opioids than when opioids are used alone. And again, in that small subset where their activities of daily living were just really, really compromised. They felt they had poor coping skills, that it wasn't going to take it away, but it should be used in conjunction with. All right. Reisfeld, in 2009, on the other hand, looked at the prevalence, significance of cannabis use in patients prescribed chronic opioid therapy, and this was a review of the literature up to that point. And they found that cannabis use was prevalent in patients who were given chronic opioid therapy, and they felt it was associated with opioid misuse. So in their review, a few years prior, they said, you know what? Patients who do smoke have a higher propensity for opioid misuse. And they also reported that there was a small but high quality literature that showed that medical cannabis for neuropathic pain. So now they're separating out one specific group of diagnosis versus arthritis versus back pain, that, hey, you know what? In 2010, this same group said, you know what? There is some really good literature about the treatment of neuropathic pain. And data from Pain Clinic revealed an unusually high prevalence of cannabis use in nearly all groups, and associated use of cannabis and opioids and other substance misuse. So a little slight difference. So he concluded that in patients who use cannabis and are prescribed opioids, there must be heightened vigilance in your dealings with them for opioid and other substance-related problems. So if you hear that this is not medical, this is not like they came in and got prescribed medical marijuana. This is all before that. This is our patients that went out and said, you know what? I heard this is going to help me. We don't have it. I'm sure no one, I'm sure people do that in this state, where they said, you know, I'm on these medicines and I'm going to smoke something because I heard it's going to help me. Not that I'm looking to get high, but it's going to help me. But you need to be hypervigilant because it could bring out other problems. He also concluded that it was appropriate to refrain from prescribing opioids to individuals using medical cannabis if there's reasonable suspicion that the combination is going to place them at risk. So he's kind of jumped all the way over to this side and saying, hey, maybe we shouldn't be prescribing opioids if we're also prescribing cannabis. And he also said it was an absolute, and I tend to disagree with this, but he came up and said it was an absolute contraindication to operating a motor vehicle. Now, there's a lot of literature that talks about, you know, acute use of medicines versus chronic use. I mean, let's face it, you put someone on a beta blocker, you know, you don't want them getting behind the wheel of a car the next day. Because remember, beta blockers make people sleepy, it impairs judgment. You know, someone takes a high dose of an antihistamine, you shouldn't take it and get into a car 45 minutes later. That can impair judgment. Remember, it's not, you know, driving while drunk, it's driving while impaired. And all these medicines, antidepressants, you know, a patient got pulled over, DWI, and we had started a patient on Cymbalta for chronic fibromyalgia, and that's why, and they were pulled over, and they said, and I said, look, we told you not to, you know, the first few days you got to be careful with this, and there's nothing we can do. I could say I gave it to her for medical reasons, but that's not going to stop that. So remember, it's driving while impaired. But chronic use, we seem to be okay. Let's look at Perrin. So again, in 2015, use of prescription pain medications among medical cannabis patients. Study looked at medical cannabis users who use or do not use prescription pain medicines. So they had 273 patients, and what they found here was that prescription pain medication users in this group tended to be older and again reported higher level of pain and lower functioning. Kind of the same as the Australian study looked at with that N of 1500, higher levels of pain, more impairment in functioning, and therefore they needed to use both to help function a little better. Okay. The prescription pain medication users and non-users didn't exhibit any difference in lifetime or past 3 months of other drugs, meaning the ones who used prescription pain medicines and marijuana were not going out and doing coke or sedatives or street drugs. There was no, when you looked at the patient populations, this group didn't all of a sudden go, wow, we're going to now explode into that. So there was no difference within the groups. And to no surprise, given the other studies, the prescription pain medicine users rated efficacy of cannabis higher than just prescription pain medicines for pain management. Not separating out and saying I shouldn't take it, but when I use this in addition, we seem to be functioning better. So he concluded, because you can see the literature is bouncing around back and forth, that's why I wanted to show this, that prescription pain medicine among medical cannabis users was not identified as a correlate for more serious forms of alcohol or drug involvement. So in this literature versus the other one said, you know what, they're at higher risk. This one said, I don't think so. So there's some contradiction here. Let's look at Olson. Cannabis use and risk of prescription opioid disorders in the US, and this is from September of 2017. And the authors concluded here that cannabis use appears to increase, you know, here we have our juxtaposition again, rather than decrease the risk of developing non-medical prescription opioid use and opioid use disorders. So we're kind of all over the board here. So there's no set literature that says, you know what, right now, we know that if someone's on medical marijuana, they're going to be going out and getting street drugs too. Okay. This is a little bit older, Buckbinder et al. Medical cannabis laws. Now let's look at the laws and opioid analgesic overdose, mortality in the United States. So they're saying, okay, in the states that implemented medical marijuana, did opioid overdose decrease? And so they looked at cannabis laws from 1999 to 2010, and in 1999, there were 4,100 opioid-induced deaths. We all know this literature. 2010, there were over 16,000, and we know in 2015 that went up higher. Opioid deaths continued to increase, but not from prescription pain medicines. The rate of deaths from prescription pain medicines has dramatically decreased. The rate of increase still is due to heroin and heroin laced with fentanyl right now. So it's not the prescription medicines, it's still opioid deaths, but you need to separate out what's going on there. So on average, the 13 states at that time, now we said there's 23, that allowed medical marijuana had almost a 35% rate lower opioid overdose mortality rate after the laws were enacted than with states without the laws. That's pretty dramatic. I mean, almost 35% less opioid deaths. So the relationship between lower opioid overdose deaths and medical marijuana straightened over time. So at first it was 20% lower at 1 year, and then it grew to 33 over 5 years. So it wasn't like it peaked in year 1 and then slowly started coming back down to the original rate. So it stayed pretty steady with that. So that's a pretty dramatic number there to say, look, if we're prescribing medical marijuana, we're going to decrease the rate of unintentional opioid deaths. Now this was what's called a working paper from the National Bureau of Economic Research. Kind of an interesting, when I was doing more research on this, found that states permitting medical marijuana dispensaries experience a relative decrease in opioid addictions and opioid overdose deaths compared to states that don't. This is more of a broader picture with that. In Hefner, I know there's a lot of literature I'm throwing out, but this is interesting, kind of different points. Concomitant cannabis use abuse dependent patients with opioids for, again, non-cancer pain. No one really looks at it for cancer pain in terms of that. So the concomitant cannabis abuse dependence in patients treated, they looked at cannabis, again, that cannabis use disorder, which is an ICD-10 and DSM-5 diagnosis, and a sample size of VA patients. What's great about VA patients? They're locked in, right? They are really locked in. Look at that N. We're talking about 1.3 million. And the last time I had the privilege of coming down and speaking here, we talked about a VA study that looked at opioids in chronic low back and knee pain. And again, it was a great capitated VA study because they were really able to track people for a year. And in that study, because they had an N of over 1,000, which is crazy to be able to track patients like that for a year. They gave people opioids, they gave people just NSAIDs for back and knee pain. They found no statistical difference between what was considered traditional dosing of like Vicodin for back pain versus NSAIDs. So their conclusion obviously was that it makes no difference, you might as well just give NSAIDs. But that's where these VA studies can come in that are fantastic. So look at this, 1.4 million people. So what they were able to demonstrate, which is really nice, was that the greater number of prescription opioid fills were associated with greater likelihood of the CUD, the cannabis use disorder. They were able to actually really track that in that many patients, which is really interesting. So their conclusions, right, that's why I'm smiling, a little different, were that increasing legalization of cannabis is likely to further increase use and abuse of cannabis in patients with prescribed opioids. So no one looked at it that way. The other studies were looking at and saying, okay, if we give cannabis, will less people die of opioids? Okay, yeah. Will there be less traffic accidents? Yeah. But they didn't look at it and say, well, what about cannabis use disorder itself? We can see what's going on with this study. So I found this one fascinating because of the patient. This is, to me, very, very strong because of the patient numbers that they looked at. Let's look at Bradford and Bradford. Medical marijuana laws reduce prescription medication use in Medicare Part D. It's all about economics. Is the government paying less? Again, what's great is you can look at the Medicare Part D population. It's a capitated population. You can look at this, and they looked at all prescriptions that were filled by Medicare Part D participants from 2010 to 2013. How many millions of prescriptions are we going to be looking at? And this was within all states, too, not just one. And what they found here was that prescription drugs for which marijuana could serve as a clinical alternative fell significantly once medical marijuana laws were implemented. So they're saying that once the medical marijuana laws were implemented, the use of prescription drugs went down significantly. So again, they could track that data, right? All right, so now it's all about economics, right? We care about people, but how much money did we save here? So look at that. Overall reductions in spending were estimated to be $165.2 million per year in 2013. That's a gigantic number. Now, they didn't say how much money people spent on marijuana, right? And what's the problem there? Because that's out of pocket. No insurance plan covers medical marijuana. And that's an issue for my patients that go and need it and want it. The dispensaries in New Jersey are horrifically expensive right now. Our governor's trying to change that by increasing the number of dispensaries. He wants to triple them. And now all of a sudden it's not in my backyard. You know, my town said, the mayor said, I will make sure that we protect our children by not having a dispensary. All right, well, where are we going to have it, right? So every town, we have what's called home rule in New Jersey. Every town has its own mayor, its police force, its fire department, adds a lot of cost. But where are we going to put this, right? And so it's very expensive. So the government may have saved all this money, but what are patients now laying out for this? You know, they don't track how much the cost has been shifted. Okay, again, this may be hard to see, but it's in your handouts. This was in JAMA in May of 2018. Association of Medical and Adult Use Marijuana Laws with Opioid Prescribing for Medicaid Enrollees. Now, we didn't look at Medicare Part D, let's look at Medicaid enrollees. The bottom line here is that the potential of marijuana liberalization to reduce the use and consequence of prescription opioids amongst Medicare enrollees deserves consideration, not 100%, but consideration during the policy discussions about marijuana reform. So this is looking at Medicaid, and they looked at state implementation of medical and adult use marijuana. So these are very interesting. They're saying, hey, we really need to look at this because, again, in our Medicaid enrollees, the use of opioids went down when medical marijuana was implemented. Okay, a few more studies. Olson, cannabis use and risk of prescription opioid disorders. So now we're not looking at cannabis use disorders, we're going to look at prescription opioid use disorders in the United States. And this was in Psychiatry in September of 2017. The authors concluded that cannabis use appears to increase rather than decrease the risk of developing non-medical prescription opioid use and opioid use disorders. This goes along with that previous paper from like 2009. So I'm wanting to present both ends. Yeah, you give marijuana and opioid deaths have gone down and some people will take less, but in a subset of population, by giving the marijuana, are we now putting them at risk for greater opioid use disorders? So this is whole Pandora's box. We open one, you know, or the Russian things, you open one, you open another. You know, we keep saying, what are we doing? We're bouncing back and forth with this. So what do? That's kind of a bottom line, right? This is very confusing literature that's going back and forth. You know, on one hand, we see literature that says, you know what? If we give medical marijuana, we're going to enhance functionality in patients who have very poor functionality or on high-dose opioids, right? We talked about several studies there. Didn't change the area under the curve. They're not using less, but they're not using more. So by giving that, is that an adjuvant? Like we have this, we say, oh, we're going to give you gabapentin as an adjuvant. We're going to give trileptal as an adjuvant. We're going to give nortriptyline as an adjuvant. Is this just yet another appropriate adjuvant to use when we've said, you know what, we're getting to high doses, I'm not getting comfortable, and we're still not getting functionality. And let's assume the patient's highly compliant. You sent me for acupuncture, I did it, doc. I got holes all over me. You sent me for PT, I'm doing as best I can. You know, these are not the patients that we talked about that won't do it. So is that an interesting concept, right? Then we also said, well, marijuana decreases opioid deaths because people start substituting that. We said that 35%. But then we've seen two papers that said, well, people who take marijuana may have a higher rate of opioid use disorder. So you can see it's all over the place with that. So where do we fit this in then? How do we work with this given, and the key word is given the current knowledge base in literature. You know, I could be talking to you now about this and I could teleport myself and come back in 10 years and I'll say, what was I thinking, you know, 10 years from now? Well, I was thinking because this is the best we can do with the literature that we have, so how do I make use of it? What do I do with this now? So, recreational marijuana is still illegal in New Jersey and Alabama, right? We know that. Well, medical marijuana is legal in New Jersey, but illegal in Alabama. So how do we balance that? So New Jersey currently has medical marijuana approved usage for these conditions. And we're a very, very strict state in terms of that. It's not like California, well, you got backache? Sure, here's your card. It's very, very liberal over there with that. Same thing in Colorado. New Jersey was set up very, very strictly. And you can see a lot of it has to do with neuropathically mediated disease, because that was some of the literature, that's a whole nother talk about, let's talk about the literature about why neuropathy versus not. But we look at ALS, you know, the Lou Gehrig's disease. We talk about MS, terminal cancer, which is interesting because it's terminal cancer, not just I have cancer, I'm being treated with chemotherapy. That's not an indication. It has to be terminal where you say, look, there's nothing else we can do. I find that very vexing. Muscular dystrophy, which I found interesting, inflammatory bowel disease, and terminal illness. Now, this is more of a generalized terminal illness. This could be anything then. You know, this could be heart failure, this could be pulmonary fibrosis, this could be end-stage liver disease. You know, if it's determined that the progress is less than 12 months of life. So they kind of put an out in there, but again, the key is terminal. Also, if all conventional therapy fails in these conditions, in other words, needing to document, with the other conditions you don't need to say they failed, but in terms of, again, glaucoma, that narrow angle glaucoma, the literature is very, very back and forth about that. PTSD was just added 2 months ago to New Jersey. Intractable skeletal muscle spasticity and seizure disorder. There is really good literature for seizure disorder in pediatric populations. Remember that whole movie of Lorenzo's Oil? Right? I think Cher was in it or something. But there is credence with that because we're intractable seizure disorder in kids. There is actually a very robust literature about that. So, what do I do? Now, I have to look at patients that are in a program or not. You don't have that luxury here. So, you know, what should you do? So, if they're not in a program, so that would be here in Alabama too, because they're not in a program. So they test positive for marijuana. I don't discharge them immediately. You know, heroin, you're out of here. Cocaine, you're out of here. Now, with those situations with cocaine and heroin, I just don't throw them on the street. I'll say, listen, I'm really, really, really concerned about you. You know, you tested positive. I'll call them immediately for heroin, for cocaine. You need to get into a drug treatment center. I'm really concerned about you. So I send them a letter stating that and telling them where drug treatment centers are. Why? Because I've been told by my legal colleagues that says that I didn't just kick them out on the street. I'm showing that I'm trying to put them somewhere, I'm helping them. Now someone said, well, you're going to put them into withdrawal if you don't give them medicine. My concern at that point is if I give them medicine, are they trading it to get the heroin? Are they trading it to get the cocaine? What are they doing with it? So I'd rather not give it to them, and I said to them, I will treat your withdrawal symptoms, which we talked about before, and I'll put you on a clonidine patch. We'll do other things to prevent that hypersympathetic symptoms, but I will not give you more opioids. And if you're really worried about it, admit yourself to a drug treatment program immediately, an inpatient program, and they'll take care of it too. So I'm covering those bases. And look, again, as I said, no one's ever died of opioid abuse. You just feel like crap for a few days. People die of alcohol abuse, right, because you have seizures and die, but they don't. So what do I do? What do I do with marijuana then? I will call them and say, listen, and they'll say, you know, doc, it's legal in other places. I only smoke a little bit. And I say, good, you know, God bless. You know, America's all about free will, right? So what I say to them is you have a choice now. It's your choice. You need to choose the medicines I'm giving you or the marijuana. Because these are people that are not in the program, right? So marijuana is very, very, very fat soluble, which is one of the reasons that you have a quick high with it too, because it crosses membranes very quickly. So when you smoke, it's going to be positive for about 28 to 30 days. But the levels will obviously be falling as you see it. So I'll say, okay, we tested at, making up a number, 200 nanograms per milliliter. You're coming back in 2 weeks. You're paying for me again. If I see it still stays at 200 nanograms per milliliter, I know you've made the choice. You've decided you want to smoke marijuana more than you want my medicines. On the other hand, if it goes down to 50, I know we're in the right place. So I will continue it. But these are patients then, as I say, lose their privileges. You know, I talked about randomly urine drug testing maybe twice a year. These are people that every time they come in for the next 6 months, I'm going to urine drug test them because I don't trust them anymore. And I had one patient, long-term patient, he's on a very low dose of an opioid. He's had, 4 successful back surgeries, I always say. Successful in that he didn't die on the table and he's able to walk, but they didn't do what they said they were going to do. And we've talked about spinal cord stimulation. He still works in construction. He's a foreman for scaffolding. And in New York City, that's really important. Every time they do buildings, they need to scaffold everything. His employer knows he's taking a low dose. He gets tested regularly there, and we keep him working. So he's afraid about a stimulator because he may not be able to work like that. One time, and he tested it, and I called him up, and I said, Daryl, did you forget to tell me something? And I've never had an issue with him before, ever. And he goes, what? And I said, marijuana? And there was a sigh, and he goes, yeah, I was at a friend's 50th birthday party, And it had been years, and I said, I don't care. All right, and I gave him the talk, and I said, and he would usually come into me quarterly because of his schedule. I said, all right, you've lost your privileges. You will come into me every month now for the next 6 months. I will be urine drug screening you the next 6 months. He made his choice. His levels were down there, and he said, my wife almost killed me for that. And he's been fine ever since, but he made a conscious choice. So that's what I tell them. I tell them, you need to make a choice, and I would recommend you do that in your practices. And if someone tests positive for marijuana, document that well and say, look, this was free will, free choice. You chose this. I said that I would not continue to prescribe because you're taking an illegal class 1 substance, right? This is an illegal substance in my state currently and in your state if you just buy it recreationally. Now, what about my colleagues in other states where it is recreational? I may have to deal with this too soon. I'm going to give them the same talk. It's like I talk with alcohol. I tell patients, do not drink alcohol with opioids. Done. It's just a blanket statement. Do not drink. If I see someone with a positive test with alcohol on a urine screen, I'm going to tell them the same thing. I'm just like, look, I'm worried because I'm more worried about alcohol with opioids than marijuana with opioids because you can die with alcohol and opioids, right? Alcohol is a very, very big depressant on top of opioids. You could die. You don't necessarily die with marijuana. However, there is that risk. I will give them the same talk. And they may say to me, it's legal. I say, I get it. But I, in my practice, will have said, it's either this or this, right? Very, very clear. I'm being very upfront, very honest with them, and I would recommend you do the same. Now, what if they're in a program? I have that. So what if they went and got their medical marijuana card, and they're being given to it for a medical reason? A little bit different. I don't necessarily accept them as a new patient, like off the street. If I get called by the oncologist, if I get called by the neurologist, I just accepted an MS patient that they were having really trouble getting control of their medications on a medical marijuana program, very compliant. The neurologist was trying to work with some opioids and it wasn't working. Because the neurologist spoke to me, I interviewed the patient also beforehand. I said, okay, I'm going to work with you because I like where we were going with that. I have them now on a very low dose methadone, which is working better in conjunction with the medical marijuana. But they have their card, they have it, we're doing tight screening with that. So, and with my own existing patients, if they want to that, I will try to wean them down to, again, more appropriate doses. I don't necessarily take them off, but if I'm sending one of my existing patients, say, look, what we're doing is just not working well, I'm going to send you to someone, because I'm not a medical marijuana provider myself. That's a separate license in the state of New Jersey. And since I'm at the medical school, we get things from all over the state, and I purposely chose not to have my own licensing for it. So I would send them to somebody. So if I'm physically sending them there, I'm saying, look, what I'm doing is not working, and I'm going to wean you down because it's not working. We'll get to a point that we get to like the almost aha moment where when we finally wean down, they go, now I feel different, because it's not getting better. So I will combine that and again work with my colleague who I sent them to get the prescription. Okay? Does that make sense to people? It's a little bit muddled, but that's how we've constructed our practice, and it's been working really well. I'm the executive director of the New Jersey State Society of Interventional Pain Physicians. We've also recommended through our state society that we've been doing it like this also. Okay. All right. And perfect. I left some time for some questions because I knew there'd be some questions with this. Yes, sir.
What are your weaning strategies?
Weaning strategies. The question here is, what are my weaning strategies when I'm talking about weaning a patient down? The key, and again, I'm not an addiction medicine specialist, so I do not prescribe Suboxone. On top of that, I'm not prescribing methadone because I'm not an MMTA provider, meaning methadone maintenance treatment program provider. So what do? I set goals up front. I say to a patient, okay, we're at this point, over the next 6 months, I always look at it as a marathon, not a sprint. If a patient's been on something for a long time, yeah, sure. Could I technically get them off in maybe 6-8 weeks? Yes, physically. But I want to deal with the mental component too of how do I balance it out to get them there. So I'll say to them, all right, over the next 6 months, this is our plan. This is the big picture of how we're going to do things. Month 1, we're going to do this. Month 2, so I set it up, and we'll try to do like, let's say, a 10% decrease each time. But we set up the goals. We set up almost the charts. So when they come in, they'll go, okay, Month 2, you ready? Here we go. So it's not like they're being surprised by that. So it's a little bit more of a work, but you can set up a realistic goal like that and say, look, if we want to reduce 10% or 15% each time, therefore, and then you can do the math, therefore it'll take me 7 months to get you off of this. I don't care. I'd rather take 7 months than do it too quickly and have them kind of relapse. So you want to do, and you can say, look, you signed on to this, and this is what we're doing. And I think that's a very, there's no magic way of doing it, but that's the way we've been doing it. I tend to take a little bit longer because of that, but I'd rather take longer because I want to get a buy-in of the patient and also, just as important, the patient's family. Like, I'll even ask the patient's family to come in. I'll ask, whether the husband, the wife, I'll say, okay, I want you to hear this too. I want to have the discussion with this. And when we're weaning too, I'll usually have my nurse practitioner come in also. So I can say in my notes that the family was discussed, the nurse practitioner is here. Why? Because what if I'm not around? There's a question. One of the two of us is around, my partners are around, they can see my notes, but I like having the other set of ears that are in the room. So I hate to say that, but in this time and day, but it's not a he said, she said thing. So we want to say that, look, there were other people in the room listening to this conversation. So there's no magic with that. If you talk to an addiction medicine specialist, they may be much more aggressive, but I'm not, and I want to do this in a long term, because I'm also not discharging these patients. I want to keep them as patients. I just want to kind of change, remember, it's turning a battleship. You got to go all the way around, and we're not just turning a quick thing. So you have to take your time with that. Does that answer that? Hopefully? Yes. Yes, sir.
Some of those studies that you showed had vague endings to them. They said things like, it appears to be, it might be, and that didn't sound very scientific or useful or factual.
Well, that's one of the problems when you have these small N studies. So when you look at the VA studies of 1.4 million people, they were a little more succinct in their conclusions, right? When you have an N of 21 or an N of 30, it's really hard. And that's why I said the research, there is a paucity of research right now, and I agree. That's why I was presenting as many, almost say conflicting studies as possible, because there was no one definitive study that says, this is it. This is the landmark study that's going to change everything. We don't have that yet.
What about the Europeans? You said in other areas of the world, they had larger studies.
There, you know what, even with that, there's still, the literature is still out. There's still nothing definitive, because no one's really studied it as in depth as it needs to be, and it's all about economics. Now people are really studying it because it's going to be big business here. And let's face it, if marijuana gets more legalized, companies like Philip Morris even are going to start producing their own brand of things. If it's ubiquitous in all the states, they're going to roll it out. Don't think they're not going to, because that's going to be big business. And once it starts big business, then there's going to be greater funding to do research. And that's part of the problem too, is all the funding now has to come through an NIH grant. And there's trouble with that. So that's one of the issues of who's going to pay for the study. That's always the problem, is who's going to pay for a study to look at that. So I agree with you. That's why I presented all this literature, because it is conflicting right now. Yes, sir.
My understanding is that smoking marijuana has the same pulmonary effects as tobacco inhalation. So, if we could subtract out the tax revenue portion of our decision-making process and the public opinion, why not make alcohol, tobacco, and marijuana illegal?
So the question was for everyone else that, yes, smoking marijuana and smoking tobacco has the same carcinogen levels. And actually marijuana has over 400 active ingredients. So people who smoke marijuana are at the same risk for developing lung problems too. That's why, just as an aside, a lot of states who are looking at more of the edible form. In other words, can you pull the THC and the CBD out of the plant so you're not using the phyto, you're not actually vaporizing or smoking the plant, but you're using it in an alternative format. The edibles, the gummy bears, whatever you want to talk about, or oils, which is a safer thing to do, that would be nice to do also. I mean, make it the federal, alcohol, tobacco, and marijuana, right? Making one big government agency. I mean, my elderly patients that need to be on it, I don't want them smoking it. Some of them can't, or vaporizing it. You think they're going to be able to contraption. And in New Jersey, it's very limited in terms of the oils that we can get right now or the edibles that we can get right now. And that's hopefully going to change too. So I agree. We need a different format with that. Absolutely. I saw a question over here. No? Oh, I did. No? Okay. Yes. I'm sorry.
I presume when you're screening for marijuana, it's THC you're looking for, is
That's correct.
So CBD oils and all that stuff, you don't care about?
No, CBD oil, so the question was, when I'm screening for marijuana, I am screening for THC. Why only THC? That's the illegal substance. CBD oils are not illegal. Why is that? CBD oils that you can buy in the state of Alabama, you can get them on the internet, they're made from hemp. They're not made from indicas or sativa, which are the two plants that we look at. Sativa is a higher THC versus CBD ratio. Indica has a higher CBD than THC. That's why indica is sometimes called Indibed. You know, it kind of mellows you out a little bit. Sativa, you say, is more the party drug, so it's a higher ratio. CBD, pure CBD oil is made from hemp. Hemp is not illegal. You know, in the Virginia legislatures in the 1600s, they mandated that every farm must grow hemp. Why? Because of sales, ropes. I mean, it's really, really strong. So that's why we don't care. If someone's taking CBD, it's not an illegal substance. The THC is what's illegal. So when you look at the marijuana plant, because that's the hallucinogen that activates the CB1 receptor in the brain. CBD oils activate CB2. And they're felt to temper the THC effect. So that's why we don't care about that. Okay? Again, that's a whole nother talk about mechanism. So any other questions? We have time for like one more. Well, thank you all so much for having me down here again. Really enjoyed being here. Thank you so much. So you guys will get about 8 minutes before the next speaker. So run to the bathroom, get your fluids, or get your fluids in versus before you put them out, and enjoy the rest of the conference. Looks like a really interesting day.